So a big welcome to those people who've already joined us. We're going to give it a couple of minutes for more to join, and we'll get started shortly. So welcome, and we'll be with you soon. Welcome to everyone who's joined us. We'll just give it another minute before we get started, and we'll be with you shortly. We're really glad that you can be with us today. So just another minute or so and we'll get going. So thank you everyone for joining us today, and a very warm welcome to this webinar from the Safety, Quality and Ethics program of the Australian Alliance for Artificial Intelligence in Healthcare. It's great to have so many people with us. We're very excited to share with you the work that the program has been doing in the last year. My name is Stacey Carter. I'm the Director of the Australian Centre for Health, Engagement, Evidence and Values at the University of Wollongong. Just a bit of housekeeping to begin. So we are recording, and the recording will be shared after the event. This is set up as a webinar, so your video and sound won't be turned on as participants, and the chat function is off, but the Q&A function is very much on, and we would love you to use it. So there's a Q&A button at the bottom of your screen, which is operational, and you can use that to add questions throughout the event. You can add those questions anonymously if you would like to. All of that Q&A will be captured, even if we don't have time to answer all of them today. We have a number of brilliant presentations, and after each one, we might take one burning question if there is one. Otherwise, we'll hold questions to the panel discussion at the end. So let's begin. First, we need to acknowledge countries. So on behalf of this gathering, I would like to take this opportunity to acknowledge the First Nations people of Australia and elders past, present and emerging. So we're going to highlight a number of projects that are happening in the Safety, Quality and Ethics program of the Alliance today. But before we begin with the projects, I'm really pleased to introduce Professor Enrico Cuero, who, as you know, is the lead of the Alliance and is the founding director of the Centre for Health Informatics in the Australian Institute of Health Innovation. And Enrico has kindly agreed to provide some opening reflections. So over to you, Enrico.
Thank you very much. Hopefully I can share my screen with you all. So I think, firstly, I'd just like to, again, on behalf of the Australian Alliance for AI in Healthcare, to welcome you to a series of webinars that we're having over the year. And as Stacey said, today's focus is very much on safety, quality and ethics of AI. And I thought in my short remarks, I would perhaps step back a little bit and let you know both what the Alliance is doing and why we're doing it. So I guess the starting point really is that healthcare is a complex business and a busy business, and it pushes us all to our limits. And at the limits of human cognition, things go wrong. We know that when fast decisions are made, humans are fantastic at recognizing patterns we've seen before, but we're not very fast at thinking through things from first principles. When we do make decisions, we tend to see what we want to see or what we've been primed to see by our past experience. We're not as rational as we would like to think we are. All of us are pretty bad actually at multitasking. And if you work in a busy ward or a busy practice, multitasking is just what you have to do to get through the day. It's surprising if you look at human memory, just how bad it is. Our short-term working memory, the memory that sort of helps us drive from moment to moment, keeps about 5 to 7 items in it at best. Not exactly a supercomputer in terms of organizing what you're doing. We're all extremely distractible, aren't we? And our devices are just making that even more so. It's very easy to shift our attention from the problem in front of us to something that's happening elsewhere. And as we've known for a long time, what anything one individual can know is really just but a drop in the giant bucket of human knowledge. So all of these limits do lead to delays in decision-making in healthcare, in errors in the decisions we make, and unfortunately, not just to costs, but to patient harms, which is really why people are interested in augmenting reasoning with technology. In other words, bringing in AI or decision support of some form. It doesn't even have to be brilliant, complex, deep learning. Even simple systems can augment reasoning. And if you're new to the area, you might be imagining we're talking about some kind of automated robot, but really there are 3 basic models for augmented support using computational systems. The first is the classic one, which is that the AI sits aside as some kind of oracle. We come to it with a question. Here's my patient with these symptoms. What should I do? And that's not often a useful model in busy practice. It's great for reflective questions, not so good for day-to-day, moment-to-moment decision-making. The other extreme is that we've got a task that is so precisely defined that we understand so well that the AI itself takes over autonomously. And the sorts of things that we do today where AI can do that are usually when they're embedded within a device. So it might be using AI to decide how much insulin to pump based on sensor readings, or driving an IV pump, for example. And the model that has emerged really over the last 2 or 3 years is this idea of AI plus human forming a new kind of a team. And if you want a mental model for that, that might be a radiologist looking at images, and as part of the image viewing system, there are tools to help them interpret or select features or direct them to particular features or suggest diagnoses. So very interactive between the best bits of what the machine can do and the best bits of what the human can do. And it's no surprise that the last 2 or 3 years, with so much effort and money going to AI, that there are literally now dozens of examples of approved use of AI in the clinical setting. And the US FDA has passed now many dozens of systems doing everything from interpreting images of retinas through to, as you can see here, guiding cardiac ultrasounds. Often when people think about AI, we do think about it in a modern resource-rich setting, but one thing I like to direct people to is to imagine those technologies helping in different settings. Imagine now if you're in a resource-poor setting, just using simple technologies, well, not really simple, but commonplace technology like an iPhone, smartphone, attach a little ultrasound to it, and then add a little bit of AI, which helps you position the probe. So you're actually imaging the organ you need to image, and then maybe doing a triage or suggesting diagnoses. Really quite transformational uses of technology in different settings. What might be a marginal increment in a major teaching hospital, in a city, in a very developed nation, could be revolutionary elsewhere. So we should broaden our view of these technologies. In terms of the research, and I always ask people to imagine what this couple is doing. I think this is the election of Donald Trump Jr. in 20 years' time. that there are three areas really where we want to focus our research. The first is really looking at the design of the machine, the algorithms, etc. And this is often the domain of computer science, much less so the applied world of AI. But we still have deep questions here about how you would build a machine that was safe and that there was ethical in the sense that it was unbiased and doing the right things. What we need to focus on more, I think, in healthcare is what we do with the technologies. How do we train ourselves as physicians, as nurses, as allied health workers, to safely use these technologies in a cooperative, appropriate, and ethical way? Issues you're going to hear about over the next hour and a bit. And the final area, I think, is to look at that notion of the team and to imagine what these future teams look like. And I have to say that this is a very emergent area of research, and it requires a lot of work. So with so much in front of us, we created the AI Alliance about two years ago. And it's really a national grouping with some international members, about 270 individuals, 95 member organizations. And our focus is to make the case to government, to industry, and to healthcare that this is an important revolution in the way we can do things, that healthcare can be transformed through the appropriate use of these technologies. And what we're going to do is to be an advocate for the appropriate and effective use of AI. So we're not technology boosters. We want to see things done well, safely, with strong evidence behind them. And to give you a sense of the membership, just under half is academia, with a good chunk from industry, which is really gratifying, and strong interest from government. It's interesting to reflect the low level of engagement at the moment from health service providers. And I think that's probably reflects that this is still not rubber hitting the road time for health providers. AI is still something that's about to come, although I would argue it's about to come very quickly. And just to finish up, the Alliance has quite a few programs. Today, you're going to hear from the Safety, Quality and Ethics Working Group. There's also a working group focusing on development and training for the clinical workforce. We have another very active group focusing on COVID-19 and looking at how we can extract the best of AI algorithms to support COVID decision-making in the pandemic. We have a strong focus on precision healthcare and consumers, something we can talk about maybe at other webinars. And as you can see, in terms of support activities, we engage in a lot of advocacy. We're about to launch a new part of our website, which will focus on just helping you find people working in an area or on a problem who have similar interests to yours, to be able to talk to people with similar interests, build networks, put together grant proposals if you're an academic. And finally, obviously, these webinars and other things that we do to try and educate and get the story out into the public. So I'll stop there. You've got a very exciting program ahead of you. The URL for the Alliance is up there for those of you who have not met us before. And we're always interested in new organizations to join. At the moment, we have a membership by organization, not by individual process, but please talk to us, and on the website, you'll see details for how to contact us, and you'll meet Jenny Waldy when you do so. So I'll stop there and we'll move on. Thank you very much.
So thanks, Enrico, for that introduction to the work of the Alliance. And now I want to pass over to a review of one of the programs that Enrico talked about. So our next speaker is Professor Wendy Rogers, who's Professor of Clinical Ethics at Macquarie University. She's also the co-lead of the Safety, Quality and Ethics working group that Enrico mentioned in the Alliance. And she's going to provide us an update on what that working group's been doing this year. So thanks, Wendy.
Thanks, Stacey, and hello everyone. Welcome to the webinar. It's really great to have you all here. As Stacey mentioned, I co-chair the Safety, Quality and Ethics work programme of the Alliance, along with my colleague Farah Maghrabi, who leads a team in patient safety informatics at the Australian Institute for Health Innovation. The SQE working group met in person at the 2019 Alliance workshop a little over a year ago, where a broad vision for the group was agreed. Our overarching question is, What do healthcare professionals, hospitals, governments, industry, and the public need to support the safe and ethical implementation of AI-enabled healthcare? The specific aims of the SQE programme are to identify what needs to be in place for AI to support safe and ethical healthcare in Australia, and to develop a research agenda based on the answer to that question to fill in any necessary gaps. In developing answers to these questions at a broad level regarding ethics, we need to perform an audit of relevant national and international guidelines and regulatory instruments to find out what's available and identify how ethical concepts are being operationalised in existing guidelines. We need to develop detailed case studies to inform the development of practical ethical guidance for the Australian contexts. Detailed case studies can identify how broad ethical concepts such as trustworthiness, responsibility, and beneficence apply in the context of a particular AI being used with an actual population in the Australian healthcare system. And we need to develop fair processes for consultation and engagement with relevant stakeholders, including the public and community, as well as healthcare professionals, government, and industry. On the safety and quality side, we need to perform an audit of national and international guidelines, standards, and mechanisms for governance and oversight at all levels of the health system, and identify and help to develop standards and mechanisms for clinical governance of AI in Australian healthcare. So very practically oriented. To implement this agenda, we propose a matrix approach based on the stages of developing, deploying, and delivering AI-assisted healthcare, looking at who does what at each stage of the AI lifecycle. Who are the relevant stakeholders and how do their roles vary across the AI lifecycle? What actions are each of these stakeholders responsible for? What kind of ethical duties do they have? And what are the safety considerations? And what governance approaches do we need to support safe and ethical AI healthcare? That sounds a little bit abstract. I've got a couple of examples to illustrate the matrix approach. During the design stage of the AI development, or for that design stage to proceed, governments need to agree and define what counts as AI for safety and regulatory frameworks, what's in and what's out. For commissioners and funders, there are questions about priority setting. What are the most urgent Australian healthcare needs that can be usefully addressed by AI? And how can we develop the right levers to ensure that we get healthcare AIs that are both fit for purpose in the Australian healthcare setting and which make a significant and meaningful difference to healthcare outcomes, rather than perhaps developing ones that are profitable but repeat tasks that are already done perfectly well. During the use stage of AIs in healthcare, we'll need community engagement to develop robust mechanisms for notifying safety and ethical issues. We'll need qualitative research to identify and report on the ethical impacts of AI-assisted healthcare on things like the healthcare provider relationship, on burdens and experiences of self-care, on conceptions of wellness and illness, and so forth. Okay, so what have we been doing in 2020? Like everyone, we have had some impacts from COVID-19, but we've done quite a bit. We've participated in grant applications and have one still pending under consideration with the Medical Research Future Fund. We're doing a project mapping safety, quality and ethics initiatives in current Australian AI guidelines. And Farah will be presenting this work in a few moments. We're participating in the development of the COVID-19 algorithm database. And we're using this project to sort of investigate and trial ways of robustly integrating ethical considerations into the evaluation of algorithms. Several of us are involved in an NH&MRC funded project, which is led by Stacey, and she'll be presenting that later. And that project's investigating the role of AI in breast cancer and cardiovascular disease. We're doing a project on ICU triage protocols with a focus on looking at how ethical principles, which can be quite broad in general, are being operationalised to help inform urgent decisions. And from that, we'll be looking at whether there's a potential role for AI in these decisions. And Eve will be presenting some of that work a bit later on. Overall, the working group's aiming for a draft green paper in early to mid 2021, and this will be to really spell out this agenda as I've been describing it, and hopefully be of a detailed nature to really sort of point to specific research areas. Anyone who'd like to is very welcome to join us. We're open to all sorts of partnerships, and please contact either myself or Farah or Jenny Waldy, who's our administrative contact person through the Alliance website. Thank you.
Thanks so much, Wendy. And we have a first question in the Q&A. So big thank you to Mohammed Khalifa for being the first person to use the Q&A function, which we encourage everyone else to do. And he's asked a really important question, Wendy, that you might want to address around what drives and should drive the agents in this situation. So are human needs and expectations driving technology developments, or are technology developments driving human expectations and practices? I wonder if you might want to address that briefly.
Look, I think it's a really interesting question, and I come to see the process as interactive and iterative, because we sometimes don't imagine how AI might affect healthcare until we see some examples, and that's been my own experience. It's not until I delve down into some examples that I could start to see ethical issues I hadn't thought of before, and you see both possibilities and dangers. But within that, I think we do need to have an overarching framework for agenda setting, and I sort of alluded to that in my talk. I do worry that if we just leave the development of AI in healthcare to the tech companies and the bright people working in this area, we might get all sorts of things, but they might not really make a difference to health outcomes in Australia. They might not be cost effective. They might not be addressing health outcomes that matter to patients. So I think we need this sort of dual process, and we really need meaningful engagement between the people who can develop things to show us what's possible, and out of that kind of smorgasbord to say, okay, these are the health problems we've got. What have you got in your toolkit that can actually help us, decrease rates of renal failure in Indigenous populations? Thanks.
Thanks, Wendy. Okay, so let's move on to our next speaker. So I'm very pleased now to welcome Associate Professor Farah Maghrabi, who leads the Patient Safety Informatics team at the Centre for Health Informatics at the Australian Institute of Health Innovation at Macquarie, and also co-leads the Safety and Ethics program within the Alliance. So Farah is going to present some results from an Alliance project that's been surveying Australian AI safety and ethics initiatives. So thanks, Farah, over to you.
Thanks very much, Stacey. I just want to check that you can actually see my slides. Hold on. Yep. Okay. Can I have a confirmation that you can see my slides? I can't hear anyone.
All good, Farah.
Cool, great. Thank you so much. So, good morning, everyone. So in this presentation, I'm going to report on the preliminary findings of this survey that we undertook this year to understand really what is the AI safety and landscape in Australia. This work was funded and undertaken here at Macquarie University, and I want to acknowledge the contributions of my colleagues, Wendy Rogers, Yves Aquino, and Kelly Hamilton, who've kind of played a key role in sort of undertaking this study. So it's a very busy and exciting time in Australia, I think, for AI particularly. We have systems being actively developed and deployed in our healthcare settings. Enrico commented that we haven't seen many organizations join the Alliance, but they are in fact actually trialing many of these systems. I've got a few examples on this slide, which is by no means kind of a comprehensive survey of what's happening, but we have, for instance, the Sydney LHD trialing an AI app for wound care. Victoria is looking at applying AI for ambulances and looking at emergency video calls for mental health. And then there's a lot of activity in the startup. So the example I have listed here is the collaboration between iMed Radiology and Harrison AI, looking at imaging applications. And no doubt there are plenty more examples. We're also seeing many of these systems in the hands of consumers and patients. So another kind of thing I should mention at this point is we're actually doing an inventory of what's happening in terms of projects and systems, and we hope to share that with you in the future. So it's really against this background that our study is being undertaken, that we're seeing systems out there already, but then what do we have in place to ensure that they are safe and that they're ethical as well. So the objective of our study was to identify any kind of initiatives, and we're using the term initiatives quite loosely, and you'll sort of see why in a second, that addressed AI safety and ethics. And we consciously tried not to sort of restrict our search just to healthcare. So as long as healthcare was mentioned, we included the documents that we surveyed. So I've got the method here on this slide. We undertook a Google search. The objective here was to identify candidate initiatives. We retrieved the documents and then assessed those against the inclusion criteria that we had. So anything that mentioned, whether it was a discussion paper, whether it was a set of actual guidelines or standards, as long as it mentioned AI safety and or ethics, we included it, and as long as it had healthcare somewhere in there. So it didn't have to be specific to healthcare. So as I said, we took a very broad approach. In the end, we selected 18 for further extraction and analysis. And our analysis focused on two things, looking at the ethical principles, and then as well as specific kind of approaches to addressing safety, which I'll come to in a coming slide. So overall, we identified 18 initiatives. My slides are not advancing. Yeah. So we had 18 initiatives all up. About half of them came from government organizations. We had some from academic and individuals as well, the not-for-profit sector, corporate, and as well as 3 that were very specific to medical organizations. All of these initiatives were published in the last 3 years. And most of them, as you'd expect, were broad. They geared towards kind of the economic sector, not specifically for health, which is what we expected with taking such a broad search. We had 5 that were specific to health, and some of these are kind of commonly known. So RANSCA, the College of Radiologists, has been by far the leader in the Australian sort of healthcare sector with their ethical principles and standards of practice that were released recently. The TGA had a consultation paper a little while ago. AI and safety and ethics is mentioned in the Digital Health Agency's strategy. We have Optometry Australia, so a professional group here looking at AI in their 2040 project. So they were looking sort of forward 20 years on to see what the landscape might be like. And AI was a big part of that. And then we also had the Australian Academy of Health and Medical Sciences, who published their roundtable report, and they had obviously a big focus on health applications. Other kind of notable organizations were AAAiH. I'll come to the AAAiH in a second. So the other one was the Data 61 and Standards Australia, who published their roadmap. And then AAAiH, as well as the Australian Human Rights Commission, which were interested mainly in the ethical, legal, and social challenges of AI. Other kind of organizations which have an interest in the area and which featured in the documents that we looked at were the Gradient Institute, as well as the Australian Institute of Digital Health. So I just want to note here at this point that these are preliminary findings. They were limited by what was identified in Google. So indeed, if you're in the audience and if you know of any specific health-specific safety or ethics initiative that we've missed out, then please do let us know. And we'd be happy to kind of include that in the inventory that we have here. So let me move on. Let me kind of review the ethics principles first. So looking at the ethical kind of concepts. So here in this graph, I've got, it shows the frequency with which each of these ethical values or principles were mentioned in the documents that we looked at. So 18 initiatives, and all 18 here, as you can see, kind of report on beneficence. We did a descriptive analysis, and the principles basically come from a framework that was derived from a previous study by Jobin et al., which was published last year. So Jobin, in their piece, they identified a list of 11 overarching ethical values and principles. So they did a scoping review of 84 international documents containing guidance or principles for ethical AI. Most of the guidance that they looked at was for general AI rather than healthcare specific applications. So as we see here, beneficence was the most commonly mentioned principle, followed by transparency, justice, fairness, equity was all kind of included in there, privacy, and as well as responsibility and accountability. And the top 5 are basically the 5 that were the most commonly invoked values in Jobin's kind of work. So transparency, justice, fairness, equity, non-maleficence, responsibility, accountability, as well as privacy. It was actually surprising that non-maleficence was, or avoiding harms was not in our top 5 values. We're not quite sure about the reasons for this. I think we need to look into this a little bit more. One of the possible reasons could be because there's an expectation that if you're looking at safety, then the avoidance of harms would kind of be addressed by that rather than kind of broadly by ethical principles. I just want to remind you at this point that the Australian guidelines were broad; they were not specific to health. We only identified about 5 that were very, very specific to health. Having said that, it's also worth saying that some of the ones that were not specific to health were doing quite a good job in looking at things that were health concerns. So, for instance, in one of the privacy ones where it was discussing kind of social, sorry, I've lost my notes here. Okay, where AAAiH was concerned with generally with privacy, but the problem of consent was was discussed fairly extensively. Okay, so moving on, overall, we found that the clinical safety of AI was not explicitly addressed. What we were really looking for here was that were there specific approaches for standardization and oversight. So standardization, we were looking for guidance and standards, and oversight, we were looking for certification, regulation, as well as broad kind of oversight. We didn't find any that was specific for health. The exceptions, of course, were the RANSCAR standards of practice for AI, which are quite extensive, as well as the TGA's discussion paper, which was looking at software as a medical device. The RANSCAR standards are quite comprehensive. They go through the development, deployment, safe use is also covered under professional standards. They also have a section that deals with audit and governance. So it's not just about deploying systems, but then what do you do in the long term? So with that, I'm going to just summarize and finish off. So what we sort of see is that it's great to actually see that there is a lot of interest in AI safety and ethics in Australia. The documents that we examined showed that there is broad agreement about the broad principles or general values that AI should be beneficent, transparent, fair, responsible, and privacy protecting as well. However, it's not really clear what these values or principles entail at the level of design and development, selection and use, and kind of ongoing surveillance of these systems. So there's definitely a gap in terms of, well, if we want AI to be safe, ethical in practice, what can we do about it? So if I was a developer and looking to do the right thing, there's not really any healthcare specific guidance about how to build a safe and ethical AI. If I was a hospital leader who gets approached by industry, wanting to trial a system, how do I make sure that the system is going to be safe and ethical for my setting? What measures do I need to take to ensure that it's going to be safe and ethical in the trial and for the patients that my organization looks after? If I was a clinician, how do I use these systems safely? And finally, if I'm a consumer, how do I know, for instance, if I was downloading an app, is it ethical? Is it going to be safe and not pose any risks to me? So there's definitely a need for more research to identify what values consumers feel are at stake when it comes to AI in healthcare, and then to also understand what those values then would mean in practice. So if you're interested in working in this area, as you can see, there's a lot to do. Please do reach out to us. As Wendy has outlined, this project was undertaken as a broader kind of piece of developing a green paper. So the next steps for us are to finalize our analysis, identify and examine international initiatives, and then move on to developing the green paper. So thank you very much.
Thanks so much, Farah, for that update on that body of work. And we have a question that follows on really nicely, actually, from what you've presented. So Timothy Kariotis has pointed out that in some of the more upstream computer science research into AI methods, ethics and safety aren't really taken into consideration. So he's wondering whether we actually need to find some way of embedding ethics and safety upstream in the research on AI methods and theory, not just in implementation.
Oh, definitely. I mean, you can't sort of bolt it on at the end. Just like any other digital health tool, you can't sort of think about these things in hindsight. It needs to be designed and built into it because there's a number of measures that if you're thinking about ethics and you're collecting data to train your AI, well, you better have collected that data ethically. Otherwise, you know, you're building on a very sort of unstable foundation.
Thanks, Farah. And we've got some other great questions, but we might hold them to the panel discussion at the end.
Sure.
So now I have the privilege of introducing myself. So I'm going to present the next session, which will focus on an NHMRC project that has recently commenced. Okay, so this project follows on nicely, actually, from the things that Farah has just been discussing. So the project, as you can see on the screen, we've entitled The Algorithm Will See You Now, or affectionately Torsen for short. And it's a detailed investigation of the ethical, legal and social implications of using machine learning for diagnosis and screening. It commenced in July this year. And this started from the place that Farah has just described, that we all know that in recent years, there has been a proliferation of reports on the ethical dimensions of artificial intelligence. So this has really raised the ethics of AI to certainly professional consciousness and also to some degree public consciousness. That has been less notable in the health domain. So there are fewer, as Farah pointed out, there's fewer reports that focus specifically on health. But as we've just heard, all of these reports tend to have a pattern in common, which is that they point to very important principles that we can all agree are important, principles that you can organise in a variety of ways. And I know one of the Q&A respondents raised that issue, you know, how do we categorise these principles? And there are different ways of doing that. So these principles are really important, but also quite abstract. And there's multiple ways of potentially conceptualising them and multiple ways of potentially operationalising them. And it's very easy to make hand-wavy gestures towards them in an everybody agrees with this kind of way without necessarily doing anything practical on the ground. And we've seen that with the collapse of very high profile ethics boards and initiatives in some of the big AI groups in the corporate world in the last couple of years. So this project started from a concern to do what Farah has just been describing, which is and which Wendy described as well, actually, doing the hard work of trying to connect those principles, which we know are important, with practice, and with practice all the way through the pipeline, to pick up on that earlier Q&A. So last year, when we were preparing this project to apply for funding, we developed a kind of desk analysis of what we thought the issues were around ethics of AI in breast screening, just as a way of experimenting with what we could do without doing empirical work. trying to bring those ethical principles really to hit home in practice. So we raised potential risks that we thought required mitigation. So things like the need to actually pay attention to patient outcomes, not just the accuracy and performance of the algorithms, to pay attention to cost effectiveness. If these are going to be very expensive, are we going to be able to justify the opportunity cost? To pay attention to transferability, which we know is always important, but is really complex in health settings, to guard against automation bias, especially in an issue that we're really focused on in this project, to make sure that AIs don't reinforce human biases and prejudices and existing structural inequities, to think about those difficult lines of responsibility, to pay attention to the potential for de-skilling where it matters, to think about data, obviously, which is probably the domain where the most thinking has been done so far, to think about privacy and the protection of meaningful choice for patients and for clinicians. And finally, and perhaps most importantly, the need to maintain trust in healthcare systems. So these were the kinds of areas that we thought needed attention. But we thought that it needed practical attention and attention that really engaged with the widest possible range of stakeholders in this setting. So before Torsen began, we had some internal funding to run an Australian survey on Australians' values towards the use of AI in health and also in social services. So we used quite an innovative methodology with a partner that allowed us to run a large representative national survey with a small number of questions and then a smaller, less representative non-probability panel, and to weight the data from the non-probability panel so we can make more representative statements based on those data. And we presented scenario-based questions. So we gave people scenarios and asked them which attributes of the AI or the application of AI mattered most to them. And we presented some use cases and asked whether people supported or opposed those uses. So we're still working on the analysis, but our early findings for people's values towards the use of AI in health included that accuracy was the thing that people valued consistently the most strongly, and cost reduction, so the use of AI specifically to reduce the costs in health systems, was the least valued attribute. And there's a number of highly valued attributes, so that these included accountability, always having access to a person, and this goes back to Enrico's comments about an AI-human partnership, the importance of explainability. People cared about explainability and fairness. And speed, we were pleased to see that the value people put on speed depended on the scenario. So people valued speed more in a scenario where speed mattered, like triage, for example. There was more opposition than support for scenarios where there was de-skilling of human clinicians and where there was non-explainability. But interestingly, there was more support than opposition for scenarios where it was necessary to share data with learning health systems, even when best quality care became contingent on that sharing. So people were more accepting of the need for data sharing that will underpin these platforms. So building on that, we have been funded for 3 years to undertake Torsen. So this is a big endeavour. I have many co-investigators, many collaborators, and I want to acknowledge all of them across 5 universities, including many of the people who are on this call. And we also have some postdoctoral fellows working on the project, and you'll hear from Eve today. So the aims of this are to start doing the work that Wendy and Farah have described. So we want to engage the perspectives of all stakeholders, and there we mean health professionals, developers, entrepreneurs, regulators, service users, the general public. We want to know what all of those sectors value in relation to AI. From the perspectives of these stakeholders, we want to map what is actually happening, so to push beyond the hype and to map what is happening in practice. We want to understand people's expectations about what will happen, and perhaps most importantly, this normative piece of really understanding what people think should happen in healthcare machine learning. We want to develop some really detailed case studies, going back to Wendy's earlier comments, that illustrate key ethical challenges in healthcare machine learning, and that's with respect both to perhaps absences, so times when those challenges aren't necessarily being addressed, but also successes. those situations where perhaps there's an innovative or a practical and useful approach that does solve some of these ethical challenges. We have a fantastic legal scholar working with us, Bernadette Richards, who is an expert in the regulation of innovation, and she is critically examining the legal and regulatory frameworks around machine learning for healthcare, particularly for diagnosis and screening. And in the end, our aim is to provide practical guidance for the development of machine learning in healthcare, with a particular attention to screening and diagnostic applications. So this is what the project looks like. So the first phase is already underway. It involves interviewing this very wide range of stakeholders and analysing documents related to the organisations that they work in, for example, or important initiatives. Dialogue groups with patients and consumers about what matters to them. Discrete choice experiments with patients and consumers, which will ask them to trade off values, because this often actually involves trade-offs, not just whether you value something, but whether you're willing to give something up to get something else. We'll run community juries with the general public, and this is a methodology that we are specialist in at AAAiH. It involves putting a difficult policy problem to members of the public and asking them firstly to hear expert evidence so they really understand the background, and then to debate amongst themselves what should happen and provide recommendations to decision makers about what should happen. And that's all underpinned by a tranche of legal research that Bernadette will do, a set of empirical and conceptual and normative analyses that will feed into our final results, drawing on the ethics literature and the philosophy of science literature. And it's all enclosed by regular stakeholder engagement and an expert reference group, which oversees the project independently. So we have AAAiH approval for phase 1. We're really excited about our expert reference group. We have an independent chair in Professor Tracy Merlin, who's an expert in HTA from the University of Adelaide. And we have representation from the Alliance. Enrico is sitting on that group, but we also have representation from groups like Vranska and Cezanne, the Cardiac Society of Australia and New Zealand, Data 61, the TGA, Cancer Australia. And those organisations have really sent presidents and directors to sit on that group, which is terrific. It means that we'll be connected very meaningfully with those groups, and we can start a conversation that hopefully will help with the work that they're doing. And we can be informed by them and what's important to them. We've started professional stakeholder interviews, and we've started some early conceptual analysis, and our first target there is to focus on information problems in AI in screening and diagnosis. So we would love to engage with you around this project, and there's a number of ways that we can do that. So we are going to hold stakeholder engagement activities once a year, and we would love to be able to invite you to participate in those. We would love to hear any feedback you have for us today on the project. And more important, maybe most importantly, we would love you, if you're a person who is involved in AI development in healthcare, particularly in relation to screening and diagnosis, or who has a keen interest, perhaps if you have a clinical facing role and you've been paying close attention to the potential role of AI in your clinical area, we'd really love to interview you for the expert stakeholder interview stage. There's a link there that can take you to an expression of interest page for you to let us know that you would like to be involved. We will circulate that link after the event as well, so that you have another opportunity to sign up. Our contacts are there. We're on Twitter, so that's an easy way to contact us. And we look forward to continuing to update you in these Alliance meetings on how that project's proceeding. So I am going to stop sharing my screen. Sorry, I've just... My apologies for that slight glitch.
Yeah. Stacey, we're running really well to time, so I thought I'd just jump in. There's a question there that you might like to answer. And this question says that we all agree that ethical standards should or must be implemented upstream as well as downstream. However, some of the ethical principles can come into conflict. Is there agreement about how to resolve such difficulties? And I thought, given that you talked about the DCEs, you might want to make a comment there.
Yeah, absolutely. And thank you to the questioner. You're absolutely right. There are sometimes situations where you can't have everything. So one of the things that we're going to be asking people about in most of the phases of this project are those trade-offs. But as Wendy mentioned, the discrete choice experiments are specifically designed to force people to trade off different values that might conflict. So what we hope will come out of that phase, which will be very much informed by the previous phases. So by the time we get to doing the discrete choice experiments, we'll have a strong sense of what's going on in the field and what matters to a wide range of stakeholders. We'll also have a good sense of what matters to people, to members of the public. And that will give us an opportunity to put particularly conflicting values to Australians so that they're in a position of having to trade them off to see what matters most. Because we know that, well, we presume that there will be some situations where performance and fairness may not be easy to achieve at the same time, for example, or privacy and performance might need to be traded off. So we're looking forward to getting those results actually, and to be able to get a sense of how people make those trades. Okay, so I'm going to now present our final speaker. So our final speaker is Eva Kino. Dr. Eva Kino is a postdoc on the Torsen project, but also has been working with the Alliance for some time. And he's going to be presenting a review that he's prepared under the Alliance of ICU triage protocols that were developed during the COVID-19 pandemic. So this is an Alliance project that began in relation to the Alliance's work on COVID-19 that Enrico spoke of earlier. And it was with a view to considering whether this kind of triage might produce algorithms where AI could make a difference, could make a contribution. So thanks, Eve. I'm going to pass over to you.
Thank you so much, Stacey. I'll just try and share my screen. Can you all see my slides? Right. So today I'm going to talk about the possibility of automating that difficult decision in the context of ICU triage during the COVID-19 pandemic. And this is a project under the Safety, Quality, and Ethics program of the Alliance. I'm presenting, but this is, of course, a collaborative work with Wendy Rogers from the Alliance, Jackie AAAiH Scully from University of New South Wales, Stacey and Farah. In terms of the background, as early as February or March, it was very notable when it comes to the surge of admissions to hospitals, but specifically to intensive care units for patients with COVID-19. And it did require triage, which is the sorting or allocation of resources to patients based on factors such as urgency, clinical need, and treatment outcome. And triage is not exclusive to this pandemic. It's a process of sorting and allocation that's very common in disaster medicine and emergency medicine, where resources become limited. And usually when it comes to infectious diseases, often you have a golden period where the longer you wait, the poorer the outcome might be. And there were a lot of reports in China, Italy, and the US, where hospital frontliners expressed moral distress when allocating limited resources, specifically because there were a lot of variations when it comes to institutional support. Some hospitals have their protocols on how to allocate that are fairly similar to existing protocols for emergency and intensive care triage. But some hospitals do not, and it was left up to the physicians and the nurses to do the triage themselves. And around this time, there was, around as early as February and March, there were a lot of plans to perhaps use artificial intelligence during the public health crisis. And in the context of ICU triage, you have a lot of potential applications. The first being the screening and the diagnosis of COVID-19, which implies the automation of pattern recognition in X-ray and other imaging tools to help diagnose patients with COVID-19. The other application is in terms of prediction and prognostication. This is where we automate evaluation of the clinical course of individual illness and who are likely to survive and who are unlikely to survive. And after that, you do have the scoring or the ranking. This is more of turning prediction and prognostication to a more numerical or quantitative value where you can score individuals, and based on that score, that's where we're going to decide how to prioritize, who will receive treatments, and what treatments will be given. And for our specific research, we wanted to identify common ethical concepts and principles in protocols and how ethical concepts are operationalized to inform ICU triage, especially during this pandemic. And we are hoping that the results of the study can identify the challenges of operationalizing ethical principles and how these might be incorporated into an AI tool that can support triage during public health crisis. It's a matter of trying to learn as much as we can before proceeding to develop algorithms that might replicate the problems, but at the same time that can fill in gaps that are not usually, that are very current because of the limitations of human skills and human cognition. We did a narrative review of ethical guidance in tools, decision aids, and protocols for allocating scarce ICU resources. And we specified our search for those protocols that were developed specifically for the COVID-19 pandemic. And we searched documents via Google and online repositories sometime between May and June 2020. And for the online repository, usually we relied on Google search and not Google Scholar or other databases because usually these protocols are not published in journals and are only available via websites, usually government websites. Online repositories were very helpful, such as the World Health Organization having a list of resources per country, and those lists usually includes position statements, ethical guidance, and preparedness protocols in each country. And we did have, we applied several inclusion and exclusion criteria because we initially found about 126 documents and we were able to exclude 106 based on the following factors, such as full text not being available in language that's not available for the authors, for the researchers, and documents that are not specific to ICU allocation or not specific to COVID-19 pandemic, and documents that have no specific jurisdiction. We were able to include 20, and we further classified these 20 documents into one, where documents with only general framework that cannot produce ranking of individual patients, and the other classification, documents with decision aids that can produce ranking of individual patients. We decided to exclude US-based documents because around April, there were already about 2 or 3 articles published that analyzed those protocols. These are a couple of examples of decision aids. One of the earliest decision aids was actually from the United Kingdom's National Institute for Health and Care Excellence. And another example is from Ontario, Canada. So here, the idea of these decision aids they're quite simple. They're visually helpful. You have here some textual explanations and arrows to guide whether the patient should go to the regular ward, whether the patient should go to critical care, or to end-of-life care or palliative care. So the same principle can be seen here. You have intensive care, regular ward, or palliative care. Once we have the 20 documents, we try to describe and extract data points. including development process. So here we wanted to determine how the documents were developed. Who were the authors? Were there any kind of consultation done? What are the backgrounds of the authors? Because you can see the difference between documents authored by ethicists exclusively and documents that are authored by medical professionals exclusively. So we wanted to identify those as well. And who were consulted during the development of the document, were consumer groups or patient groups consulted? Did the document involve funding from the government or other kinds of resources or organizations? And more importantly, we wanted to extract criteria for ICU triage. So these are explicit ethical, medical, and social criteria for ranking and sorting individual patients. We also wanted to extract information about recommendations regarding how the triage should go. Who are the members of the triage team? Should primary care physicians be involved? Should non-medical professionals be involved? And what responsibilities are for the members of each triage team? We also wanted to evaluate the usability and impact of the document. At this moment, it's still very difficult to say and look at evidence of impact because in terms of usability, we wanted to try and describe the document, or does the document have decision aids that are very helpful? Because often medical professionals in triage situation will not have time to sort through a 50-page document. So usually if the document has a decision support tool like in the image, it's much more usable and much more helpful. I'd like to focus a little bit on the ethical, medical, and social criteria for this presentation. So here are the common ethical concepts discussed in the documents. You have autonomy and self-determination. Usually when they discuss patient preference, if the patient prefers not to be admitted, then that is a categorical, then the patient should not be admitted. And that's respect for autonomy and self-determination. The issues of justice, beneficence, and maximizing utility, as well as the duty to provide care, were also very common. But each document tends to have different interpretation of these concepts. And when it comes to the medical criteria, the common ones include clinical need, the presence of comorbidities, prognosis, including response to ICU treatment. Usually prognosis is also interpreted as survivability, short-term, mid-term, and long-term. And the use of illness severity scorings. Just to give you some examples, these are common clinical scoring tools used in hospitals and were mentioned by a lot of the documents included for this study. One is SOFA, or the Sequential Organ Failure Assessment Score, and it tries to assess 6 organ systems, and the higher score, the less likely the patient will survive. You also have the Clinical Frailty Scale. Some documents exclusively propose one kind of scoring tools, but other documents sort of warn against using just one scoring tool, or at least the scoring tool is just one of the criteria for ranking and sorting individual patients. Apart from the ethical and medical criteria, we also have social criteria, which is quite controversial. When it comes to social criteria, should we use social status, social value, or caring responsibilities? We were only able to encounter one document that espouses social value, but it's very poorly described. And it's just one statement. We might have to consider social value. Caring responsibility occurs more as a recommendation, whether we should prioritize medical professionals or those who are in the front line. So individuals who are working in the hospital who are not medical professionals should also be considered as part of the front line. And some documents explicitly recommend to prioritize medical professionals when it comes to ranking and when it comes to receiving intensive care resources. We also have the recommendations regarding first to arrive or lottery as another way of allocating resources. A couple of contested concepts include age and disability, because usually these are both medical and social criteria. Some documents do warn against discrimination against age and disability, but at the same time espouse the use of a clinical frailty score, or use age as part of another scoring tool. And for the further analysis, I'm not going to discuss, but I just want to point out that we want to look at the tension among ethical principles, for example, maximizing utility versus justice or equity. We also wanted to look at tension among criteria such as age as a clinical variable versus age as basis for unjust discrimination. We also want to look at how we operationalize difficult concepts such as fairness, solidarity, and dignity. Thank you for your attention, and thanks to the Safety, Quality, and Ethics program of the Alliance. Thanks to Wendy, Jackie, Stacy, and Farah. I'll stop sharing now.
So thanks very much, Eve. We're right on time, so I might actually ask everyone to turn on their cameras, everyone who's in the panel, and we might get started with the panel, I think. And the first question we might take from our audience is around to what do we compare when we're trying to evaluate safety and ethics? So are there existing frameworks around safety and around ethical principles that we might be able to use as the standard to evaluate AI in healthcare? Or do we need new ones? Do we need to create new frameworks? I wonder if Farah, you might want to talk about safety, and Wendy, you might want to talk about ethics.
Okay. Yeah, look, as far as safety is concerned, if you're thinking about introducing an AI system, obviously it can't pose a greater, like it's got to be as safe as existing care or existing processes. It can't definitely pose a greater risk than what we have at the moment. If it's safer and faster and better, then good, but that's kind of the very basic starting point.
Yeah. Stacey, in terms of ethics, I mean, I think we've been doing clinical ethics for thousands of years, and fundamentally, the patient's best interests are at the center of healthcare, and the advent of AI isn't going to change that. And in general, I'm against kinds of exceptionalism. I don't think we should have AI exceptionalism in terms of ethics, but I think AI just tweaks or pushes things in different directions. And one example is responsibility. So when you just have a clinician making a patient making a decision with a patient, clearly if they miss important diagnostic clues, or they're out of date or whatever, they're responsible for that. Once you have an AI assisted decision, then the allocating responsibility becomes more complicated. So we don't take away the fact that if the patient's harmed, that's bad, and if someone's made a mistake, they should be responsible. It just gets a bit more complicated as to how you unpack that.
Thanks, Wendy. There's another really important question in the Q&A that Enrico and Farah might want to address, which is around the extent to which consumers and patients in the general public have been consulted so far on thinking about what a good AI might look like in healthcare. And I wonder if either or both of you might want to comment on the degree to which you think there's been public consultation around the development of these tools to date, as they kind of sit on the verge of implementation, but not quite there yet.
It's a really important question, and I think we can guess the answer is going to be not as much as necessary. The interesting challenge here also is that we're not just talking about consumer contributions to thinking about how tools should be used in clinical care, but there are many tools designed for consumers. So, for example, it's now a common service in many countries. In fact, you can also use here in Australia these so-called symptom checkers, where you go online, there's an algorithm that analyzes your symptoms and makes some kind of recommendation about whether you need care or not. And these are very controversial. Their safety remains often uncertain and not validated in the standard way. And there's very little talk around, I guess, the risks and benefits of divulging very private information to a database. You know, stuff that you might normally divulge to a clinician, you might be less comfortable with, for example, divulging to an algorithm that goes and sits in somebody's database and can be hacked. So I don't know, Farah, what your views are, but I don't see an awful lot of consumer engagement either around clinical use or more importantly for consumer use of AI.
You know, there's very little. We do know that the Consumers Health Forum is interested and keen to work in the area, but not much has been undertaken in Australia specifically.
Mm. Thank you both. So there's a question for me, which is around the degree to which the use of AI in healthcare should be guided by the preferences and values of users. And that might also be something that others might want to comment on. So I probably bring a bias to this because I direct a centre that focuses on using innovative methods to engage with the values of members of the public and service users. So my answer is always going to be, yes, those values absolutely have to be taken seriously. One of the issues with any technology like this, though, and really with any problem in health and medicine, is that there's a level of expertise and knowledge that's required to be able to think well about it. So it's not fair, I think, to expect people to have deep insights about the technology until they understand it. So the community juries that I talked about earlier are a process for trying to address that gap. So to give people access to really high quality evidence around a problem, and then to ask them to debate in a very inclusive, diverse group around what should happen. And I think if those sorts of processes are run in a kind of ideal way, so in a way where deliberation is authentic, where people are supported to really be able to participate, people are selected carefully, people are informed well, I think we do really need to take their recommendations seriously. And we tend to do multiple of those processes across the country, at least we did before lockdown, and we will do it again. And at the moment, we're trying to do replications of them online. And we find that generally people come up with similar recommendations in those multiple groups. Sometimes with slightly different reasoning sitting underneath, but the recommendations are often quite similar, which increases our trust in the findings that we generate from those processes. So I think there's a role for everyone, which is why the Torsen project is engaging with a wide range of professional stakeholders as well, because we think it's really important that everyone's preferences and values and also practices are taken seriously. Did anyone else want to comment on that before I move on?
I mean, I guess I've just got a general comment. You know, I've got a long-standing interest in boundaries, and if we're talking about AI healthcare, we have to be pretty clear what we mean by healthcare. And I think that comes up against patient preferences sometimes, and priority setting, which I've already mentioned. And I think it's a really complicated nexus, and I just don't think we do healthcare priority setting kind of really well in a really, you know, thoughtful, holistic way yet.
Mm. Yeah, I would agree. Thanks, Wendy. So there's a question for you, Eve, which may be a comment or maybe a question that you can answer about a project. Mark Howard has raised a project at MIT. The MIT Moral Machine is doing a public survey of decision-making associated with triage for COVID-19 that covers the categories of ethical, medical, and social. So he was wondering whether you had an opportunity to look at that work, or it might just be a heads up to connect with the work that
Thanks, Mark, for the question, and more to read. But I am aware of the Moral Machine on driverless cars. So it's a set of questions that you can answer and anyone can answer. I am not familiar with the COVID one yet, but I assume it's more of a survey of people's perception. And it's still a little bit different. It's different from what we're doing with our research because we're looking at recommendations that have clear jurisdiction. So we're talking about protocols authored by people who are decision makers in the clinics or from regulatory bodies, from the government. And those recommendations are usually practicable. And to some extent, these recommendations, if you don't follow them, you're not following certain protocols, and you might be punished for not following. So it's different from surveying perceptions of ethical, medical, and social concepts. It would be an interesting, it would be really interesting to look at those results, and we'll try to look at that soon. But I think it's different from what we're doing. But thank you for the question.
Thanks, Eve. So the next question is about rolling consent. So I might start with Wendy and then maybe ask Enrico and Farah whether you might want to respond as well. So the question is whether there's AI projects around rolling consent under consideration. And Juanita Fernando says, I can see an enormous role for AI projects in this domain, not the least of which is around the electronic medical health record system. So I wonder whether you might like to comment on that idea of rolling consent, Wendy.
Look, I think it's really vexed. There's a spectrum of views on how we should approach, consent for access to data, and at the very highest levels of privacy protection, should there be a requirement that any uses of personal data only occur with specific explicit consent from the person who provides the data or to whom it pertains. And then at the other end, there's this view, in a way, an idealistic common good view that, we're all in this together. If everyone's data is used, we'll get better healthcare and everyone will benefit. And so on that basis, we don't need individual consent. And there are practical considerations that cut across those views as well. I don't think we've really landed anywhere yet. I think those are conversations that we still have to have. And then there's also this kind of, not double think, but discrepancy between the amount of data that people, willingly or unknowingly give to Google, Facebook, Amazon, Netflix, whatever, versus once it's called healthcare data, these protections should come in or are presumed to come in. And then we get this blurring, as Enrico's mentioned. What do you call a symptom diagnosing app? You can download half a dozen and put in your symptoms and, get any number of conditions diagnosed by them. And who knows where that data's gone. So at the moment, it's a huge mess. In terms of practical considerations, I guess probably my view is that it's going to be very difficult to get informed consent from everybody for all of the uses of their healthcare data. I just think it's going to be reasonably impracticable. And so what can we do to make sure that the uses are still ethical? I think then we're looking at how the data is protected, how people are informed about what the uses are, if there is possibilities for opt-out. So those are the kind of where I'd be looking for solutions, I guess.
Thanks, Wendy. Would anyone else like to comment on that question around consent and health data and medical?
We let the ethicists handle that one.
So the next question is a really great one, which might be for Enrico and Farah, I think, which is around the adaptability of AI systems, particularly for critical decisions. Like triage and the allocation of ventilators. So Andrew Madry points out that at first everyone thought that intubating with ventilators was the most important treatment to be allocating in the context of COVID-19. And over time it was shown that actually outcomes were not what was expected, and different forms of treatment started to be instituted, which would mean that if any AI system was assisting with the decision, it would have to be highly adaptable. So I wonder if either or both of you could comment on that adaptability.
Sure, I might start, and it's a good question. I guess the question is, where does the information come to say that we need to change treatment? Let's say we go from not ventilating to not ventilating. It's quite possible that that was a statistical analysis or a machine learning analysis. So in fact, AI might play a part in recognizing that such a change needs to happen in the first place. The second part of that is about the algorithm that you then deploy to assist in making a decision. I guess this is a question about how often do you update? And really the answer is that you can update in real time should you wish. There's a computational cost in rebuilding a model on the fly. So, it is possible for decisions which we know are being made in uncertain territory, where data is coming in and our view of the world is changing, to update as you go. So that's in fact the the core power of machine learning. And one of the flip side is the worry when people build a model based on a data set and then deploy without ever checking if the algorithm actually still works or not. So one of our big concerns is something called transportability. I've built my model based on population X. Now I deploy it to population Y. I actually need to check that it's still going to work. So I would actually say it's incumbent on developers to check, maybe not in real time, but frequently, that they do need to update. So it's a very important issue.
And if I could just add in, like, there's also a role there for then ongoing surveillance of these systems. You can't just deploy and say, right, it's working. You need to kind of keep an eye on what's going on at an institutional level, but then also kind of at a national level. If you have multiple deployments, because then you might see kind of, one event at one site might not mean anything, but if you have like a cluster of events happening, then, you go, well, hang on a minute, we need to be looking further at this.
Thank you both. So the next question is about public understanding of AI, really. So the question is, are we doing enough to educate and inform people about the use of AI in healthcare, and a concern that perhaps people have baseless fears about the application of AI in healthcare. So I might take that to start with and then throw to anyone else that wants to make a comment. So in the survey that we did, which I must emphasize as a survey, so what we're prioritizing there is trying to get a broad and representative picture rather than a deep picture of people's values. But given that caveat, we saw actually there was much more support for than opposition to AI in general, and also a general positive view towards the use of AI in healthcare. So it certainly wasn't strongly swung against the use of healthcare AI, but with some variation for different kinds of applications. So I don't feel like we come away from that survey with a strong sense that the public is kind of frightened of and pushing back on AI on principle. But it's also the case that, and anyone interested in AI would know this, that there is a lot of hype, a very complex and somewhat breathless discourse around AI in the public domain. So it's quite difficult actually for people to get access to good information if they're just picking up information casually. So then I guess that raises a question that others might want to address, which is around how we might educate and inform people about the coming uses of AI in healthcare. I wonder if Enrico and Farah might want to comment on that.
Yeah, look, I think it's quite a pressing issue, because today we're talking about healthcare, but everybody who owns a smartphone or uses a web browser or uses Facebook or Twitter is having their information filtered through AI. People probably don't know that there's a personalized stream coming just to them, designed to get their engagement already based on machine learning. So I think we're living in a world where our cars, our home entertainment systems, our communication devices are all being, in one way or another, filtered, manipulated, or changed by AI, often to our benefit, but also with risks. And we know one of the big risks, say, with social media is that you end up creating echo chambers, and people tend to aggregate to ever smaller groups. If you've watched The Social Dilemma, you'll know what that's all about. So I think there's a broad societal discussion, not just about healthcare, where people obviously have specific concerns, but about what AI can do.
Farah, would you like to add, or should we move on?
I think we can move on.
Okay, thank you. So the last question from the Q&A I'm going to put to Wendy, actually. So Wendy, there's a question about whether AI might risk widening the gap in health disparities, whether it might make injustices worse. And I wonder if you might want to comment on both the importance of that as a concern and what we might do to address it.
Yeah, it's certainly a concern. And there are well-recognised fears about discrimination and bias in terms of the training sets used in AI and exclusion of people who are otherwise suffering various socioeconomic disadvantages who don't make their way into the data sets. I'm more familiar with American examples than with Australian examples, but there's been a couple of papers on these issues where one paper was looking at healthcare costs and sort of how much money should be allocated for the healthcare costs for different cohorts of patients, and the algorithm said that Black patients would need less money for their healthcare than white patients, and it was based on historic use data. And so although the Black community in this area were medically underserved, this counted as them not needing much healthcare, and so less money was going to be allocated for their healthcare. There was another instance too where Black patients were not allocated appropriate appointments because it was assumed that they would not attend their appointments, and so they were given kind of like 2 or 3 people at one time on the assumption that some of them wouldn't turn up just because they were identified as Black patients. So when we get biased data sets, obviously we'll get algorithms that don't come to fair decisions. So that's kind of one aspect of it. Another aspect of it, I think, is cost. Are we going to get very expensive AIs that might or might not be, in Australia, for example, approved by the Medical Services Advisory Committee, so that we end up that only people that can afford it can use the AI augmented healthcare, which may or may not be better. On the other hand, there's some AIs, there's one that I'm fond of, I suppose, is one for doing retinal photography. It's being deployed in America and in Europe. It's called IDXDR. And this has the capacity to do screening retinal imaging for diabetic retinopathy. And it means that people, instead of having to travel to a distance and have their pupils dilated and sit there for 2 hours and so on, can have the images taken just when they're visiting their GP. And the rhetoric around it is that it will bring down costs as well. That analysis hasn't been done, but it has the potential to both be more convenient and cheaper than care provided by a human, which would then decrease inequities by decreasing cost and making access better. So I think it's possible that it can pull in all sorts of directions. I think we know enough now to be aware of where the pulls and pushes might come from and to try and look out for them.
Thanks, Wendy. So we're coming to the end of our conversation. Thank you so much to everyone who's participated. And I'm going to end by asking each of the panelists to give us just a 30-second quick comment on our title, actually. So you might recall we called our seminar Hope, Hype and Humdrum, or rather Or Humdrum. And I wonder if each of you could just give us a quick comment on the balance between hope, hype and humdrum in healthcare AI at present. Eve, maybe we can start with you. So maybe Eve, Wendy, Farah and Enrico.
Thanks, Stacey, and thanks to everyone who attended. I think what we have to consider is that medicine and healthcare have different domains. They might be disparate and they have different intricacies. And I think hope, hype, and humdrum can coexist in different domains. What we have to learn is that what works in one domain of medicine, for example, clinical medicine, may not be applicable to another domain, such as public health. Or the other way, where AI works in one domain, we can assume that it will work in another domain. So I think we have to consider and add new ones when evaluating applications in different domains of medicine. Thanks, Stacey.
Thanks, Eve. Wendy?
I guess I think the hype is probably a bit overinflated. There's shiny new toys. They're very expensive. They're very exciting. People want to throw money at them. People want to have them in their practices. So I think that's a worry. And I think the hype draws attention away from what might be considered the humdrum aspects, which is like, what is healthcare for? It's about improving health outcomes. It's about decreasing burdens of morbidity and mortality. It's about making lives better for people. And I'm worried that we lose sight of that very sort of humdrum, basic, fundamental aspect of healthcare with all the excitement and the hype.
Thanks, Wendy. Farah?
For me, I think I kind of, hope resonates a lot with me, because I think especially with the fantastic kind of work that we're doing in the Alliance, we brought together both, the safety work as well as the bioethics. And so we're in a unique position to address these issues and to kind of do them well. So I'm very hopeful and excited.
Thanks, Farah. And Enrico?
Look, I think we're moving from the big hype, which is very tech-driven, because what's happened in the last 2 years is the technologists have discovered healthcare is hard and digital health is hard. And so what we're doing, as Farah said, is, I guess, jumping into the space and helping people be a bit more rational about where to start, what might work, what may not work. And that is exciting because we know we'll make change. But you know, a little bit of hype is good because it gets the funders excited.
So that's a good point to finish, I think. Thank you so much to all of our participants. It's been great to be able to spend time with you. The recording will be available after the event, and a special thanks to all of our panelists and speakers. So we'll look forward to seeing you at the next Alliance webinar. Thanks, everyone.
Thank you. Bye.
Thanks, everyone.
Bye.
Bye.